Most of the patients who develop non-Hodgkin's lymphoma are over the age of 60, which is quite different to Hodgkin's disease, which tends to be a disease of young adults. Most of the patients we're seeing now are over the age of 60, and we see patients in their 80s and even early 90s who develop aggressive lymphoma, and they expect and deserve the same approach to treatment that we use in younger patients, that is trying to actually cure the disease. With many types of non-Hodgkin's lymphoma, it's really all or nothing. You either cure the disease or you are fated to die from it. So we really, in older patients, get one opportunity to put it into remission and hopefully cure it. And despite the advancing age of most patients, we can now do that. The major advance in the last 10 or 15 years has been in supportive care, so there is not a lot different with the treatment that we're actually using. We're using chemotherapy that has been used for decades, but we're using it much more wisely, and the supportive care enables us to give that safely to patients well into old age, so they can actually have the same intensity of treatment. And it's the intensity of treatment that's crucial in curing lymphoma. Well, we know that delivering chemotherapy, it's terribly important to get the right dose and the right amount of treatment to patients to cure the malignancy. And this has previously been hampered by toxic effects of chemotherapy, so treatment may be lowered in dosage, it may be truncated in duration, and that leads to inferior outcomes. With the better supportive care, and particularly growth factor support, we can allow the bone marrow to tolerate treatment much more and deliver effective doses. The traditional approach to treating aggressive lymphoma was to administer chemotherapy at 3 to 4 week intervals, and the interval was necessary to allow the bone marrow in particular to recover from the toxic effects of chemotherapy, and that's the period during which patients are susceptible to infection. Now, by shortening the interval between treatments, the rationale was to attack the lymphoma at more regular, consistent intervals and not allow any breathing space or any time for resistant lymphoma cells to develop. And this has really been made possible by the use of bone marrow growth factors, which accelerate the bone marrow recovery, so that shortening treatment from 3 weeks to 2 weeks could actually treat the lymphoma better, and patients were able to tolerate this with the use of growth factor support. It's really all or nothing with lymphoma. We have to eradicate every single lymphoma cell to put patients into remission, and anything left behind, particularly any resistant cells, means that their lymphoma is fated to simply return. John was, in many ways, very fortunate. He had a blood test performed to check his cholesterol, and it was on that blood test that he asked his own GP to just add in a blood count, and his blood count was abnormal. And John, being a general practitioner, spoke with the pathology laboratory about what that might mean, and he was told that he most likely had a form of chronic leukemia, which was a relatively benign illness and something you probably didn't need to worry about. So when John came to see me, there were some characteristics about his blood that didn't quite fit that diagnosis, and that just emphasises to me that one of the most crucial factors in treating lymphoma is getting the diagnosis absolutely correct. Any slight misjudgment on what type of lymphoma it is can lead to disastrous outcomes. So in John's case, he was perfectly well, but clearly had a very nasty type of lymphoma that really only became apparent when he had analysis of his bone marrow. even in the last 3 or 4 years, we've had considerable advances in treatment of this particular type of lymphoma by increasing the intensity of chemotherapy and by combining that with an antibody treatment, which is a novel approach to the treatment of lymphoma. So I was fortunately able to tell John that he was unlucky enough to have a very rare resistant type of lymphoma, but that new treatments were very, very successful, and that he could look forward to an over 80% chance of being in remission 4 years down the track. Well, it was a very difficult time. It's always hard when patients are perfectly well, and it's difficult for patients and particularly those in the health industry to grasp the concept that they're unwell on the basis of a blood test, which they can't see and they can't conceptualise. So, but once we went through the diagnosis and he realised what was happening and the potential for a good outcome with treatment, we just got on with the job. It's a very long, arduous process. John was treated for almost 9 months. He spent a lot of that time in hospital. He would be in hospital for 2 out of every 3 weeks. The treatment was quite intensive. There were periods when he was quite unwell, and his treatment culminated in a stem cell transplant using his own bone marrow, which had been cleared of lymphoma and restored to health. And John is notorious for being the earliest discharge I've ever had following that procedure. I think he was out of hospital by day 12.